You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Everyone, we are back with our Citations Classic Shoulder and Elbow. Today we will be talking about the Ream Run procedure. We have some classic articles kind of describing when it was first started and then going all the way up until about 8 years ago with some follow-up on this procedure. Same team as before if you've tuned in the past. I'm Sam Fuller. I'm a PGY2 at UB up in Buffalo. We also have Brad, who just matched to his shoulder and elbow fellowship in Denver. So congrats to Brad. We have Teja, Matt, and Jalen. They both just matched to residency. So congrats to them. And as always as well, we also have Alex Macfarlane. So we will go ahead and jump right into it. Alex is going to start us off with some background information, and then we'll get into the articles.
All right. Yeah. So you guys picked a pretty cool topic, and I think it is certainly kind of coming back into the public eye now more with some more advanced technology. But we're doing the Ream and Run. So on the left, you see the video of the Ream there, and you see I guess one of our local Bonus guys here doing his little run. So next slide here. So I'd have to be, I have to mention Dr. Matson. You can hit, next a couple times here. It'll show a spread of all of his articles here. I'm pretty sure all of the articles we're presenting today are his work, and he's really been the guy doing the work on this. He's up at University of Washington. He's one of the originals of shoulder, and there's a great AICS podcast that he does where they interview him talking about his time with Dr. Neer and his time and why he did shoulder. And the guy's going to be a neurosurgeon initially, but he asked, who has the most fun in the operating room, and the anesthesia team told him orthopedic surgeons. That's how it happened. You hit next, and you'll see his blog post. Huge resource. I know people who listen to this are into education, all that. You get a weekly blog post from him, and for me, I still use it too. It's pretty impressive stuff. He goes through all the literature. So next slide here. That's a little funky. I think you maybe went too far, but you see us cementing here. You see the Lazarus lines here. The idea is that this is the weak link is the glenoid. So the idea of Ream and Run is ream the glenoid. You don't necessarily run away, but you replace the humeral head. Because that's not the weak point. The weak point is really just the glenoid. You're putting plastic on a glenoid and expecting it to stay stable for the rest of life. You have these really young patients, as we'll see. We're talking about an average age in mid-50s, which is pretty young for arthroplasty. And at the time, certainly when this was developed, and even, somewhat still now, is the glenoid is the loose point or the weak point. It's not that, it comes loose, I got to put something else in. It's not a big deal. When these get loose, they cause polyethylene debris, and just like we talk metal debris, that polyethylene debris can be quite bad, and it can cause osteolysis and this massive bone loss. And the thought is, hey man, if you're out in Washington, you're climbing mountains and skiing and weightlifting and being active and using your shoulder, you might loosen this up, and that's going to cause a big issue down the road. So why don't we try to do something that it's not going to be a grand slam, it's going to be a base hit, and it's going to prevent you from maybe some issues down the line. If you hit next too, one of the things we know with shoulders is that there's this sort of edge loading concept that a hip, when it rolls around the socket, is really kind of, its point is focused in the middle, or its weight bearing focuses in the middle. Shoulders do edge load. And he talks about this in his article. We know this quite well. It doesn't really sit concentrically there. And so if you have a polyethylene that's not fully seated, it kind of wiggles around, you got to think of something else, because that polyethylene will come loose, and we call that the rocking horse phenomenon. So you hit next. So the idea is that, do you innovate the technique? Do you innovate the glenoid component? We'll talk first in the next slide about innovating the glenoid component, and Dr. Matson thought about innovating that other stuff. So what we see here, you can show that slide. The introduction of highly cross-linked polyethylene, which we talk about a lot in bearing surfaces now, it really took that loosening rate of the glenoid down. This is from the Australian registry, even to the point where we're talking revision rates are sort of on par with reverse revision rates. So that's always the reverse. the debate is reversomania. Are we just doing reverse for everybody, or is this other option viable? So if you hit next two, you'll see some illustrations of different technologies that we use, including insect glenoids or inlaid glenoids. Let's not get too deep into the terminology, the difference of those two, but basically the idea that you're sort of quartering out a rim and you're setting it in, and it's kind of like a manhole cover they compare it to, where you're not getting that rocking surface. And then the other component too is this hybrid fixation. So a actual ingrowth surface and cement on the pegs there. So that's another idea of how do we do this to loosen. But if you go to the next slide, this is kind of the idea here. And this is especially younger patients you're talking about. Patient selection. And then after patient selection is restoring concavity of the glenoid. So you have a lot of posterior glenoid wear. And if you look at it, the B2 glenoid, it's kind of got that rough surface. The idea is to restore that concavity by reaming, not taking down the high side and bringing them from a bunch of retroversion to neutral, but just restoring concavity so you can get that humeral head to stick in. Preserving bone stock goes along with it. Again, I'm telling you not to bring it to neutral. It's bringing them back to a concave surface. And that soft tissue balance, he goes into a lot of these articles talking about preserving the posterior glenohumeral ligaments, rotator interval closure. And for those who have seen a total shoulder arthroplasty, we're taking the capsule, we're taking the labrum and the capsule off. And this really, you're leaving the labrum. And, I was interested in one of these articles or reading that, a huge consideration. I mean, the vast plurality of times they left the biceps. Kind of didn't really realize that until I read this stuff. But also, you're not taking the labrum. You're more taking the capsule off of the labrum versus the labrum with the capsule off the bone. It kind of makes sense the more you see of these, but it's a much, much different procedure. And they make a big point. This is not a hemiarthroplasty. This isn't just like sticking a head in there saying, go crazy. There's a lot of technique to it. And then there's always the glenoid size mismatch just to get the head to sock in there into the deep socket. And you can hit next. And he talks about getting the osteophytes off and all of these different ways it can impinge. It's really a deep dive into how to do it. Most important thing that I really enjoy is what he talks about is patient selection. These are, again, younger patients who want to be active, who are willing to say, hey, I don't need 100% pain relief. I just need my motion back. And I'll go through the hard rehab. As you'll see in one of these studies, it takes them a long time to get to where they're getting effective treatment out of this. And they're not getting back to, I'm totally pain-free, my shoulder's normal. It's just better. And it's better to the point where they can go and do what they want and say, hey, I want to live out my 40s and 50s not worrying about this glenoid. And then, when I'm finally ready to slow down and take on the restrictions of what's needed for a total shoulder arthroplasty or reverse shoulder arthroplasty, let's do it then. Let's make that surgery easier. So next. And then on the horizon with this, and really why I think this is a cool topic that you guys decided on now is the idea of pyrocarbon as a bearing surface. This isn't necessarily new in orthopedics, it's just new in shoulder and new in the application of it. But it's no longer cobalt chrome, which we use in most of our bearing surfaces, right? You're using now pyrocarbon, which is a softer metal. And the thought is that this will, after a small run-in period, won't wear on that glenoid as much. Because at the end of the day, you put in a hemi and it wears. And that's kind of part of the reason that these get revised a little bit earlier is glenoid wearing. But, and that fibrocartilage covering we'll talk about, but hey, maybe this won't wear on it as much. And that's what some people are thinking now, but this is very, very early. For those in the wards and in the operating room, maybe talk to your shoulder attendings about this and see what their opinion is. I guarantee you'll get controversy.
All right, so yeah, this is one of the initial studies by Dr. Matskin on a canine model, and I view it as more of a initial biologic study just to see what actually happens when you ream the glenoid and how does it interface with the prosthesis on the humeral component. So next slide. So the study, it consisted of 12 canine models, all female, aged 1 year. And they underwent a humeral head replacement with their glenoid being reamed. And they followed up these results at the 10-week interval and the 24th interval, looking at the biologics to see how um, these reaming kind of changes the glenoid interface and if it allows for any bony healing. And they had a controlled population as well, which was the contralateral glenoid to compare it with. And specifically, the surgical technique was done with a DePuy implant and the glenoid ream with a 15 millimeter spherical reamer. And kind of the post protocol for these canines were they allowed passive range of motion at day 10 and allowed exercise to begin at the 1 month post-op. And again, specifically looking at the biologics at the 10 and 24th week interval, they specifically looked at the histology, looking at the bone density, the soft tissue composition and thickness, and able to use fluorescent labeling to look at how much of the bone is growing, and used a laser displacement scanner as well. So next slide. So the results, all 12 dogs survived the initial surgery and there were no infections or complications, and the PT protocol afterwards were no issues. And at the 10-week interval, Dr. Matzkin and his team observed that the surface of the glenoid became partially covered with granulation tissue or trabecular bone, so that early signs of fibrocartilage formation. And they found that the initial arthritic components were able to be clearly transected. And then at the 24th interval, they saw that the entire surface was covered entirely with fibrocartilage, and it showed an organized osteoid. So those results were very promising in terms of seeing how you're able to remove the arthritic portions of the glenoid and still allow for pretty significant bone healing at the 24th week interval. And the bony remodeling specifically is about looking at the density was about 15%, which was after surgery, to 33 to 43% of the reamed area had increased bone density. And using the labeling, they were also able to observe the osteoblasts at the subsurface region. And like we mentioned before, one of the main advantages of this technique is to preserve soft tissue. So they were able to initially measure over 1.6 millimeters of increased soft tissue coverage over the 24-week interval. Next. So the main conclusion here is that the spherical glenoid reaming, it's able to produce a pretty consistent healing response and allow for the preserved concavity like we mentioned. And this is able to be securely interfaced with the articulating humeral prosthesis. So the bony healing response using reaming showed remodeling of the trabecular bone and formation of the fibrocartilage interface, which is then able to interface with the components. And we observed increased glenoid depth, width, and bone density over the 24 weeks. But again, important to be mindful that this study didn't really standardize based on the level of arthritis, and the post-op protocol in these canine models is pretty different from the usual protocol from what we use in this technique, where we allow immediate weight bearing and load bearing. And the follow-up, again, limited at the 24-week interval. So although we are able to observe pretty consistent bony growth, it would be more helpful to have long-term data. And in terms of actual physical outcomes in those canine models up to the 10-week, there aren't really models to describe the level of pain or their level of function. And it's important to know that they did have a residual limp from the surgery. So in terms of those outcomes, it remains unclear. But overall, the study is a pretty significant initial study that helps show the biologic interface and healing that can be observed using the reaming on the glenoid and then using the arthroplasty for the humeral component.
Yeah, exactly. That was a great review of that article and also a great introduction by Alex. So that kind of sets the basis for everything that we're about to review kind of further here. And that's a great intro into how this all got started with the canine model. So we'll have the next article now talking about that.
For sure. The second article we're going to talk about is titled Self-Assessed Outcome at 2 to 4 Years After Shoulder Hemiarthroplasty with Concentric Glenoid Reaming. This is another study done by Dr. Matson and Lynch out of the University of Washington. It's a single surgeon prospective study from 2000-2003. They had initially 38 shoulders, but 35 were included in the study. Inclusion criteria included glenohumeral-degenerative joint disease, the patient being less than 65 years old with moderate activity expectations, no previous arthroplasty or infection of the shoulder, and as well as having sufficient glenoid bone stock and cuff function. These patients would then undergo unsubmitted humeral arthroplasty and reaming of the glenoid, or Ream Run, which we've been talking about, and having a diameter greater than 2 millimeters of the glenoid than the prosthetic humeral head. These patients also had to have at least 2 years of follow-up. The average age of this patient population was 57 years old, predominantly being men. And the outcomes that they looked at for the study was patient-assessed comfort and function via the simple shoulder test, which is a standardized questionnaire assessing 12 shoulder functions, which has a max score of 12. They also looked at range of motion and independent radiographs, which were evaluated by 4 different observers. There was no specific or no direct control group for this study. However, they did compare their outcomes and simple shoulder test scores with total shoulder arthroplasties done by the same surgeon. And so they hypothesized that patients with severe glenohumeral arthritis had improvement in self-assessed shoulder comfort and function at 2 to 4 years after treatment with hemiarthroplasty and concentric glenoid reaming without prosthetic interposition. Looking at the results, the average initial simple shoulder test score was 4.7. After surgery, the final follow-up score at least 2 years of follow-up was 9.4. So this showed an increase in 4.7 in terms of patient assessed shoulder function and comfort. Overall, 32 shoulders improved from their initial score, 1 was unchanged, and 2 became worse. Again, the simple shoulder test or simple shoulder test score is a 12-point system, and out of those 12 different points, 10 out of 12 of those functions were significantly improved at follow-up compared to initial for patients in this study. And then also of the 256 initial absent shoulder functions, which were basically of the 256 that were part of the simple shoulder test function scores, 181 were regained by the patients, which equated to a 71% likelihood of regaining lost functions from this surgery. And of the 164 initial present shoulder functions that were present in this population, only 17 were lost. So this was a 10% likelihood of losing function after undergoing this surgery. In terms of looking at range of motion, forward elevation and external rotation, both were significantly improved from their pre-op measures. For forward elevation, it was 60 degrees pre-op. At post-op, it was 138 degrees. For external rotation, pre-op was 14 degrees. Post-op was 42 degrees. Continuing with the results of this study, again, the final simple shoulder test was significantly greater. Also for individuals with radiographic evidence of regenerated joint space. So if you're following on YouTube or looking at the website, you can see and appreciate on the right the definite lucency that was created between the humeral prosthesis and the Ream glenoid bone, which represents that regenerated joint surface without evidence of any kind of posterior wear following surgery. Also, patients with concentric glenoids had improvement in their simple shoulder test compared to patients with eccentric glenoid preoperatively. The study also had no infections or instability or any patients revised to its total shoulder arthroplasty. One patient did undergo repeat glenoid reaming due to secondary pain and stiffness, but at final follow-up, their simple shoulder test score was a 12 out of 12. So in conclusion, this study did find their results that they found supported their hypothesis that the technique can significantly improve self-assessed comfort and function of patients with follow-up of at least 2 years. And specifically, it doesn't subject these patients to the risk of glenoid component failure as they are just reaming the glenoid. And again, of the 12 simple shoulder test functions, it was able to improve significantly 10 of the 12. The two that were not improved included the ability to carry 20 pounds at each side and the ability to toss a softball 20 yards underhand. Also, this study found that patients' comfort and function measures were not affected by age or surgical history when it was stratified by that. With this study, the follow-up time was only 2 years, 2.5 years for the average. Therefore, we do not know the long-term durability of this study, specifically with the patient population having an average age of about 57 years old. There was also no prospective comparison group. It was compared to total shoulders done by the same surgeon. So it's really unable to conclude superior versus inferior method with no direct control. And finally, being a single surgeon study is unable to be generalized to be able to be replicable across institutions and surgeons.
Okay, awesome. So next we're moving on to the next article, once again by Dr. Matson and his group. This study was published in JSES, titled Non-Prosthetic Glenoid Arthroplasty with Humeral Hemiarthroplasty and Total Shoulder Arthroplasty Yield Similar Self-Assessed Outcomes in the Management of Comparable Patients with Glenohumeral Arthritis. And this was published in the year 2007. So looking further at the study, going into the design of it and how they set the paper up. So this was a case-matched prospective study in which patients chose the procedure, whether they wanted a total shoulder or the Ream Run procedure based on the risks and benefits presented to them, as well as their overall goals and what they wanted to achieve from surgery. So this study they took 120 patients from a database with those that had a Ream Run procedure, and they selected 35 patients with a minimum of a 2-year follow-up. They then they selected a blinded investigator who selected 35 comparable patients from TSA data by similar surgeons with comparable demographics. And these patients were matched by the diagnosis of disease, as well as sex, age, operative site, and the length of follow-up. And then they also included pre and post-operative shoulder comfort and function documented using the simple shoulder test that Jalen just described. And these simple shoulder tests were recorded at each time intervals and compared with unpaired t-test. And the data collected was at 6, 12, 18, 24, 30, and 36 months post-operative. So ultimately, the hypothesis of the study they believed that humeral hemiarthroplasty with non-prosthetic glenoid arthroplasty would offer a recovery of self-assessed shoulder function similar to that of TSA, but the time for recovery and comfort and function would be longer than that of shoulders having conventional TSA. And for those following along on the video, we can see table 1 showing the demographics of patients with the Ream Run group and the TSA groups showing comparable characteristics among the group. So looking at the results of the paper, they showed that both TSA and Ream Run procedure showed substantial and comparable improvements in the SST scores. The initial SST were similar, with a mean of 4.5 in the Ream Run group and a 4.0 for the TSA, which was had no significant difference. The final SST was 8.12 for TSA and 6.67 for the Ream Run, and this was at the 36 month mark. This was not statistically different, but they did show that at 12 months follow-up, the total shoulder group did show improved final SST scores with a mean score of 9.6 versus 7.8 for the Ream Run group. And once again, this was statistically significant. But at the 18-month mark, the results no longer showed statistical significance, as we can see in the graph here to the right, as well as the table. And so these trends continued upward, as we can see shown in figure 1 here, but there was no statistical significance at the end of the 36 months, just this change at 12 months. So from the conclusions of the study, the authors were able to elicit that at 2 and 3 years post-op, shoulder function improved after Ream Run is similar to the total shoulder when the procedures are performed on comparable patients. They also demonstrated that Ream Run can be considered for young active patients who are willing to ensure longer recovery times, who want to forego the potential complications of glenoid component failure with TSA. But they also elicit that longer studies needed to be used to draw conclusions on efficacy and durability of the Ream Run procedure. And all studies are not without limitations. Some potential limitations of this study is that this wasn't a prospective randomized control trial. Not all patients provided data at the desired follow-up times. It was a small series of patients with limited follow-up, and follow-up did not capture time when glenoid components typically fail in TSA, typically around 5 years.
All right, thanks, Matt. So next we'll review the article, Can the Ream Run procedure improve glenohumeral relationships and function for shoulders with the arthritic triad? So again, this is another paper by Dr. Matson and his group. So for study design, this study was a retrospective review of 30 patients who underwent Ream Run for the arthritic triad. They define the arthritic triad as glenoid biconcavity, so a B2 type glenoid with retroversion greater than 15 degrees and posterior subluxation of the humeral head. The study question that they wanted to investigate was, can Ream Run improve glenohumeral relationships on axillary radiographs, and can it improve patient-reported shoulder comfort and function? So their main outcome that they looked at was humeral centering. And they defined humeral centering as the location of humeral contact point with respect to the AP dimension of the glenoid. You can kind of see in the picture there, for anyone who's watching on YouTube, how they measured that. So they measured it as the ratio of the distance from the anterior glenoid lip to the contact point divided by the distance between the anterior and posterior glenoid lips. So basically the ratio of the segment C in the photo there to segment G. And then other outcomes that they looked at, they compared pre-op Walsh classification and then pre and post-op glenoid version. And they also looked at the SST post-operatively as well. So for the results, they had a mean follow-up of 3 years, range from 2 to 9.2. Of the 30 patients, 28 were available for review. They did have 2 patients who were ultimately excluded because they underwent revision to anatomic total shoulder arthroplasty for persistent glenoid-sided pain. Their main outcome, humeral centering, preoperatively, they had a mean of 75% posterior subluxation pre-op, and this was reduced to 59% post-operatively, which was an average of 16% difference. And then there was no significant change in glenoid version between the two groups, and there was also significant improvement in the SST from pre-op to post-op, similar to some of the other studies that we've seen. Pre-op SST was 5, and then they improved to 10 post-operatively. So in terms of conclusions from this study, I think this study shows us that overall Ream Run can improve glenohumeral relationships and restore humeral head centering on the glenoid in patients with the arthritic triad. This is through a combination of both concentric reaming of the glenoid, and then they also talk about how they'll use an anterior eccentric humeral head on the humeral side for the hemiarthroplasty part of the procedure to help maintain that centering. And Ream Run pretty reliably demonstrates improved shoulder function in these patients, again, similar to how we've seen in the prior studies that we've discussed tonight. This can be a good alternative to anatomic total shoulder arthroplasty to avoid the complications associated with the polyethylene glenoid components. And then in terms of limitations, we already kind of touched on it in some of the articles, but some of these results may not be generalizable to all surgeons, since this is a high volume center and patients do kind of seek out Dr. Matson's group specifically for this procedure. And he's definitely doing a lot more of these than some other areas around the country. And then they did have a large loss to follow up from the initial patient pool. So a smaller sample size, only 30 patients. They may be missing some patients who weren't included due to loss of follow-up. And then this study didn't directly compare to anatomic total shoulder arthroplasty. So those are the main limitations there. But I think it's a interesting study. I know there's definitely some debate today between there's some people who are in the camp of you can kind of leave the glenoid version where it is as long as the humeral head stays centered, and I think this study shows that you can get good results with that. And then there's some people who prefer to correct the glenoid version back to as close to neutral as you can get it, and I think ultimately that question is still a little bit unanswered. But this was one of the early studies specifically looking at Ream Run and the glenohumeral relationships, and I think it did a good job of that.
Yeah. If I could mention just a couple of things briefly. I mean, Brad pulled up the bigger thing when you're talking about single surgeon studies. It's the big thing is you can always use that. Oh, maybe you're just so good at it that only you can do it. A lot of surgeons will be like, hey, I'm just a normal guy like the rest of you. But the patient population, the specificities, people seeking it out. For those interested, like looking at the CAM procedure, the comprehensive arthroscopic management, that's also kind of the same thing of like these people are young and they're educating themselves and they seek out these specific things. So it's the idea is that there's this self-selecting bias that, hey, these patients are going to do good because they wanted this. And once you let a patient do, in with some respect, do what they want, and they kind of get to be part of their care, they can have a lot of success. The other part, just to pull it up before this one comes up for anyone listening, if you're noticing a theme, the simple shoulder test, it's a Dr. Mattson's thing too. It's very functional. It's important, these research things, that kind of know that like how these different scores work, and so like, oh, this score they did really well. It's statistically different. Like the ASES score, which you'll see a lot, has like pain, function, and then a total. Certainly pulling from what they learned from the simple shoulder test, but the simple shoulder test is like, can you do things the shoulder does? It doesn't really ask about pain. It's from like, can you work full time at your job to can you throw an overhand softball 20 yards? And can you pick a gallon of something up and lift it 8 feet? So it's very much like a functional thing. So, and this is what this idea is like, hey, your pain may not be perfect, but does your shoulder work to a certain level that you'd expect your shoulder to work?
Awesome. Thank you for those clarifying points, Alex. Definitely really important. And we'll finish up with the last article here. So this is functional outcomes of the Ream Run shoulder arthroplasty, a concise follow-up of a previous report. And that previous report we already looked at. Again, this is work all by Dr. Mattson. So this one was in 2017. So this is the most recent follow-up of that we're going to present here. So this is about 8 years ago. The study design of this was to investigate the 10-year implant survivorship and outcomes. This one has the 176 patients who underwent the Ream Run between 2000 to 2008. And again, they were evaluated using the simple shoulder test that we just talked about preoperatively and then annually postoperatively. The percentage of maximum possible improvement was calculated for the SST score. They used a formula of the total score at the time of follow-up minus their score pre-op times 100%. And then they divided that by 12 points, which was the total points that you could achieve, and subtracted that from the total score preoperatively. And then this was considered meaningful improvement after surgery if that score increased by at least 30% of the maximum possible improvement. So kind of a different way to look at things. Usually you see minimum clinically important difference reported. They said that this is more capturing of whether or not these patients are actually improving, because there's kind of a ceiling effect with defining a minimally clinically important difference. So kind of what Alex just alluded to is that this is a pretty simple shoulder test and essentially looking at their functional improvement. So their results, again, the average age was the same as the prior studies, 56 years old with 91% males. Since their original report about 10 years ago or 8 years ago, prior to this one, they had 4 revisions of their Ream Run procedures. 2 of them converted to a total shoulder, and 0 actually converted to a reverse. The original report that we kind of went through, so they have 22 subsequent procedures, 2 manipulations under anesthesia, 5 subscap repairs, 4 open soft tissue releases, 1 arthroscopic release, and then 5 revisions, Ream runs, 6 totals, 1 revision, reverse. 19% of those patients underwent additional surgery. SST for the unrevised shoulders tended to be better in terms of their outcomes. So they had 10 out of 12, kind of what we had seen before. If their shoulder did undergo revision for whatever reason, those tended to have worse outcomes, and kind of unsurprisingly, but pretty striking difference at 4.4 compared to 10. Again, if you're watching on YouTube, you can see this graph here. So they have their kind of Kaplan survival curve, and you can see that red line there that after a couple years it goes down, but it kind of tends to level off after about year 5 or so even. And then obviously all the way out to 16 years, those are only a few of the patients, the early ones on. And then the table 1 is kind of talking about their 2 and 5 year outcomes as well. In conclusion, though, this says essentially functional improvement was reported in these initial series, and it was sustained at this 10-year follow-up. There was only 6 subsequent procedures performed in those 6 years since the original study, which 4 of those were revision Ream runs, and 2 of them being totals. And again, none of them were revised to a reverse, which I actually found pretty surprising. I thought by this point, 10 years out, at least one of them would have been revised to a reverse. But again, I think this kind of goes back to what we've been talking about this whole time, is that these are specifically picked patients, very strict selection criteria. They said that the rate of subsequent procedures declined after the first 2 years and then kind of steadied off. And again, like we've been stressing this whole time, this must only really be considered in a highly motivated patient. So with that, thank you all for joining for this episode of the Ream Run, and essentially a look into Dr. Mattson's work. If anyone else has anything to add, otherwise, we'll see you again for the next one.
Yeah, thanks, Sam. I thought you did a good job summarizing that last article. One thing that I will say is that, like, obviously, like, these are some of like the classic articles, and I think that you're kind of surprised over not having seen any of those patients get revised to a reverse. I think that that's changed a little bit. University of Washington was one of the places I interviewed for fellowship. And when I was talking to the faculty and the current fellows out there, they said that it's probably like a kind of a 50-50 split as to like ones that are getting revised either to like another anatomic or like a revision Ream run versus a reverse. And the reason why they're seeing that more commonly now is because of, similar to like how with an anatomic you can get rotator cuff failure. That's a problem for these patients with the Ream runs too. So I think that was a good point that you made. And I think that maybe if they kind of redid this study now, that they would have definitely more patients in that revised to reverse category.
Yeah, and I mean, it's just like, it's now that it's just such a much better surgery at this point. Like, I mean, you have people like just saying, the reversomania, like, dude, I do reverse for everyone. Like it's certainly a different thing here. And that pendulum is like swinging so much, who knows? But it's certainly a better surgery for revisions than it certainly was in 2008, let alone even, 2017. Like, we weren't really sure yet.
Thank you all for joining. We will see you in the next one.
All right. Strong work, guys.